Y'all, like I said earlier, I am back with Roland and Zack from the Hemophilia Alliance. And I just want to say at the end of our last conversation, the both of you said, hey, by the way, there is this thing that is creeping. It's becoming prevalent. Prevalent? Is that a word? Prevalent. Prevalent. Oh my God. Prevalent in insurance plans, especially looking to 2025. You had some urgency about wanting to talk about kind of the next iteration of the accumulator and maximizer issue in alternative funding programs. And so we immediately scheduled a time to talk about this. And on purpose, Zack and Roland, I did zero research. And so I guess to start us, tell us a little bit about why the urgency, what is starting to happen, and how will patients be affected by these programs?
Yeah, so I think I always like to kind of level set a little bit, right? So we have copay accumulators out there, and that's essentially when all copays don't count for the patient, right? So we have copay maximizers, and that's when plans alter their copay amounts to maximize the amount that a manufacturer would give for patient assistance through a copay card or something like that. And these alternative funding schemes is what we're calling them right now, just because there is no name. But we're identifying where it's harming patients and their ability to access medication. So ultimately, someone has insurance. That insurance should pay for the medication that their doctor prescribes. In this case, a third-party vendor enters the chat and takes the prescription and says, we will still get you your medication, but that's actually through the manufacturer patient assistance program, free drug through the manufacturer. And so those manufacturer programs aren't set up to be a pharmacy for patients, right? They're not there for 24/7 emergency situations. They're really set up for patients who don't have insurance. And this is essentially taking that medication that should be filled at a pharmacy, doing a lot of things in the background, and then making it look like the patient doesn't have insurance to those programs.
Whoa.
So there's a lot.
My mind broke a little bit. What is the, and I guess Roland, I guess I'll turn it to you. What is the thinking from a fiscal perspective? Like, why would insurance companies do this, or a third party do this?
Yeah, so these third parties are emerging, right? They're generally for-profit entities providing a service. They generally get paid as a percentage of the savings to the health plan. And what they have sort of accumulated is a lot of knowledge around manufacturer assistance programs that are either generated as by the manufacturer. Sometimes they're funded through government agencies, but they're really intended for people with significant financial need. And so what they do is they, as Zack was saying, they carve the benefit out for certain specialty medications. They force the patient or the consumer, the covered person, to access product through the vendor, and the vendor sort of acts as a facilitator to the patient assistance program. And there's some ramifications to that, right? So that's not why these programs were set up, number one. Number two, you might be on a product that the vendor may try to push you to a different product because of available manufacturer assistance. So, same product, might be more than one product to treat somebody with factor VIII, for example. So you could end up potentially being pushed to a different product, or at least attempted to be pushed to a different product. And then there's all sorts of other unintended consequences. As Zack mentioned, you might not get assistance, you might not get copay accumulators or those kinds of things. I think the biggest issue is that because manufacturer assistance programs were not set up for this purpose, a manufacturer might say, hey, we need to tighten the reins on, tighten the program on this assistance plan. And then the consumer gets left out, right? So if it cuts off mid-year and your benefit already excludes it, what happens? I mean, basically, your only option is to present yourself to the emergency room, which is not exactly where you want to get your care and your product from. So, yeah, I think that there's just a lot of unintended consequences from this. And really, the whole goal is to save money to the plan. Milliman did a study. Milliman Actuaries did a study, and they sort of hedge their bets on whether there's long-term savings in the aggregate from this, because there's a fiduciary responsibility of the sponsor of the health plan, and so if people run out of care, run out of coverage, run out of product, there's still got to be a way to access product, and forcing people to the ER and those other things is not a particularly economical solution.
Zack, both you and Roland work at the Hemophilia Alliance. Both of you are part of the member and community relations team. Tell me a little bit about your role with the HTCs in particular, surrounding issues like this, insurance issues like this that might affect those affected with bleeding disorders.
Yeah, I mean, we get calls from our treatment centers that say, we've submitted an authorization for this patient. It's been denied. And now the patient received a call from one of these vendors. And they don't always present themselves as this vendor. It seems like they're part of the PBM or the pharmacy network, right? And during that call, they're telling the patient, oh, we need you to sign some paperwork. But that paperwork includes a limited power of attorney. It includes things like a release of medical records, including mental health records or substance abuse records, things that they don't need, but they are making the patient feel like they have to provide that in order to get their medication. And so the patient's kind of caught up like, oh, I need my medicine. Let me sign up for these things.
Yeah.
The treatment center is working in the background saying, oh, well, this pharmacy denied it. Maybe we can try another pharmacy. So they're spending a lot of administrative time calling, going through the list of pharmacies that the insurance has set up and trying to make sure the patient has medication. And you can imagine, this can happen all of a sudden where the patient doesn't have medicine on hand. And maybe there's an issue where they need medication sooner than later. And so there's a lot of scramble at the HTC. How do we make sure the patient has this medication? Obviously, HTCs want to prevent the ER visits. Sometimes in these situations, that's where the patient has to go to get that medication. So our HTCs are concerned both on the administrative work that's happening to ensure patients have access to the meds. Patients are worried about what information they're giving up to get on this medication. And then sort of unbeknownst to the patient, because they signed this power of attorney, because they've given them access to the medical records, they're filling out the patient assistance forms on behalf of the patient and submitting it. So the patient doesn't even know where the medicine's coming from. And that's really problematic, obviously, is like, who do I call? How do I get these meds that are so important to me in a timely way? And so sometimes those alternative funding vendors will act as that third party. Oh, tell me how many doses you have on hand and what the strength is. They take that information. They then will call the manufacturer, and then the manufacturer will send the meds to the patient. So it becomes very convoluted for the patient, complicated. A lot of people are putting in a lot of work to make sure a patient's okay, but sometimes it's hard to know who's on first.
Oh my gosh. Are these third-party vendors being contracted by the insurance companies? Like, is this like a...
They usually, they're typically...
Is this...
Yeah, they're typically brought in maybe by brokers, consultants, in an attempt to sort of offset renewal costs. The insurance plans themselves, maybe not necessarily. They are generally these alternative funding programs are sort of standalone businesses of their own. So they're marketing, hey, let us help you. Your drug costs are rising. And the good news is we don't charge you anything unless we save you something. So it sounds like a pretty good deal. And I think that's the issue.
And Roland, actually, that's a good clarification. This is happening mostly in self-funded employer plans. And so for those of us, explain that to me and to the audience like we're in third grade. What is that? And yes, please.
Yeah, so it's a little tricky to explain, without a whole bunch of slides. But
Yes!
in a self-funded employer-sponsored program, the employer is essentially piecing together a health plan, choosing a network, choosing a claims processor, choosing a prescription benefit manager, choosing to pay claims themselves, and buying reinsurance for high cost claimants, for example. So they're essentially, the self-funding aspect is that the employer is paying the bill for the insurance program, and by virtue of that, they hold a lot more decision-making authority than, say, a small account that, small employer who goes out and buys a Blue Cross or a United or a Cigna health plan. They're beholden to the rules set by that health plan. But the majority of people in the United States are covered under these self-funded programs, large employers making decisions with counsel. They get good consultative advice from brokers, large brokers. And this business has emerged, another sort of vendor with, the marketing pitch that they're going to save you money. So it gets a lot of attention because specialty medications are on the rise. And, in some cases, they're about a third of your overall premium in terms of the cost of them. So it's an important issue for sure. But, I think there's just a lot of implications, maybe not well thought.
Roland or Zack, whoever wants to take this one, what's happening with the 340B pharmacies in terms of this issue? Are plans typically having, two choices of pharmacy, a 340B or another pharmacy, or this alternative funding program? Or is it just like, are the 340Bs being completely cut out?
Yeah, well, remember that when these programs are set up, they don't distinguish between 340B and non-340B plans. I mean, there are complications of being a 340B entity in self-funded programs where the employer chooses a pharmacy benefit manager that has exclusive rights to distribution. And so they shrink the network and sometimes carve our hemophilia treatment centers out of network, even though we may be a better and more economical option. So they do that because they have their own distribution capabilities and they want to make the surplus on drugs. It's really not a distinction between 340B and non-340B. Remember that the core issue of this alternative funding program has to do with qualifying patients who meet the financial test, the needs test, right? Because these premium assistance programs that they're generally using through the manufacturer have a means test. And so the plan might say, well, these manufacturers cover people up to 300% of the federal poverty level. If you're above 300%, we'll cover you on the traditional plan. But if you're under, we're going to push you to this alternative funding mechanism, which brings into question, what kind of information do I know is being sourced out about my economic means? Are there HIPAA considerations? Are there tax implications? Has the employer violated its fiduciary responsibility to the plan? Is it discrimination? So I think it exposes the employer to a lot of legal issues that nobody's really ever talking about. And as a patient, I may not know what information is being provided to these vendors.
For sure. This is giving me anxiety. Everybody, I should have done research before this so I could have been prepared for the anxiety inducing. Okay, so if you're a patient, how will you know that this is happening to you? And what do you do? Does it get down to the patient? Is the HTC kind of the first line of defense, or does it trickle down to the patient and the patient alerts the HTC that this is happening? What have y'all seen? Should the patients look out for this, and what should they do?
Yeah, I think from a patient perspective, oftentimes the treatment center will receive a denial for an authorization for the medication. And then sometimes the next step is that the one that was reviewing that and denied them reaches out to the patient and says, oh, we're going to get you set up on a new pharmacy plan. This happens, a patient might switch from specialty pharmacy A to specialty pharmacy B throughout, when plans change. I think sometimes our patients are used to having to re-enroll in these things. Mm-hmm. It just takes a little bit of this feels like a red flag. And I think if a patient has questions during that, they should reach out to their HTC and say, hey, I got this packet of paperwork, or I got a phone call saying this. Does this seem to jive with what you know about my benefits plan? I think patients we all have spidey senses at some point. And I think when we feel that this doesn't seem right, we should start doing a better job of talking together. Hey, HTC, is this correct? HTC to patient, hey, we seem to get a denial from you. Let's work through what this looks like in the next steps. And I think it just requires a lot of communication between both parties.
Yeah, I was going to just add, I think what the core of what Zack is getting at is it's really important for patients to understand it's okay to advocate for yourself. The unfortunate byproduct of some of this for people with severe illnesses and severe diseases is that sometimes they need coverage, they need the product, and they're reluctant to ruffle feathers with their employer, right? And so, but I think it's really important for people to understand there are rules, there are things that they have as rights. Their plan has a fiduciary responsibility. They have a right to equity amongst the employees that are in the account. There are provisions in ACA sponsored plans that protect them. So they have rights. They have to get educated about those rights, and they have to be willing to advocate for themselves, so they don't just get left out in the cold and have to go to the ER for care. And so that can start with the Hemophilia Treatment Center, because there are teams of people with, been through just about every issue. They have no problem advocating for patients. They have us at the Hemophilia Alliance in the backdrop to help guide the situation. But it's really, really critical for the message to be that it is okay to advocate for yourself in these situations.
Are patients, can they say no to these programs? And if they do say no to these programs, where will they get their medication?
Yeah, some of the way these programs are written are pretty tried and true. And so sometimes they don't have immediate options, but I think they start to raise questions about the program and the way it's structured, and get, appropriate counsel from treatment centers, from us at the Alliance, from other member advocacy organizations. I think it's probably not something they're going to turn the needle, turn this on a dime and move the needle right away. But I do feel like it's something that they're going to have to continue to advocate for, because while they may not feel as big an impact in the short term, although we have had some cases that have been emergent, the longer term aspect of this is where I think the concerns are. Keep in mind too, as Zack was pointing out, if people have immediate bleeds or need product immediately, some of these patient assistance programs take up to 3 or 4 weeks to even render an opinion about the application. So this is not a perfect science.
Yeah. And do you think where this is going is patient advocates and HTC advocates speaking to their employers about signing up for these particular programs, identifying these programs, and here are some ways to maybe cut costs that wouldn't necessarily be as clear Is that where we're going?
There's a white paper out there right now that
We love a white paper.
yeah, and it's aimed at employers about how alternative funding schemes are bad. And it goes into all the points that Roland was talking about. I think too, we have employers that buy into these programs. They're looking for savings, right? Costs are high. You can't blame someone for thinking, okay, how do we help reduce the costs so that we aren't increasing our premiums? So sometimes the employers don't even know what they signed up for. And what we found is when we talk to the HR department, sometimes those HR folks are like, oh my gosh, we had no idea this is what we did. That's not what we were told. That's not what we were sold. We will help make this right.
Right.
I will say there are other employers who know what they're getting into. And that is a much more difficult conversation because they are much more embedded in that savings and can be more standoff to the patient. And that gets really complicated. And why I think it's important to engage with local advocacy groups, national advocacy groups when reaching out to your HR. So you have some support there and how to navigate that and knowing your rights, as Roland pointed out earlier.
Yeah, and I think you're going to see manufacturers get a lot smarter about this and what they require for evidence. One of the questions might be on the application for financial assistance or product assistance might be, do you have access to health coverage? Or does your health insurance plan cover these products? What's the answer to that? If you know that, you make $50,000 a year and you qualify, but somebody, across the hall makes $300,000 a year and they can get product traditionally through their insurance plan like anyone used to. So what's the real answer when you're asked, does your insurance cover this product? So I think you're going to see manufacturers get a lot smarter as this thing expands because, it's their dime. Yeah. And,
Run 100%.
So I feel like eventually it's going to restrict what's available for people that are in great need. These programs it's like the marketplace exchange. It wasn't set up so that employers could dump high-risk people to the marketplace exchange because they could get subsidies on their premium. That's not what the purpose of the marketplace exchange was. But I think some of these well-intended mechanisms like exchange subsidies and premium and product assistance and those kinds of things, they're just being exploited. And I think the rules will just tighten eventually.
Y'all, thank you so much. It feels like this is just like the start of this conversation, and we'll continue to talk about this. Before we go, just wanted to ask y'all, where can patients go in particular for more information to kind of educate themselves even further about this issue? Where can patients go?
So NBDF is working on their insurance toolkit, which I think is a great place for patients to go in this period of time, right? Open enrollment's coming, understand what a lot of terms mean, deductibles, coinsurance, all these things. But they are also working to identify these, reaching out to your hemophilia treatment center. Oftentimes there's people there that can help you work through your insurance options. They can't always point you to which one to pick, but helping you understand those or referring you out to an insurance specialist in your state who may know the different opportunities available.
Yeah, I'd say, Google is your friend. It's sort of like, I can.
Whoa, no one ever says Google is our friend. Really, Roland?
I feel like, you can fix your lawnmower with a YouTube video now. So I feel
yes,
like, if people Google pharmacy benefit alternative funding programs, funding programs, you'll see a lot of information out there. I'd encourage people I think a great resource is the Milliman white paper. The Milliman actuarial white paper is a really great resource. But there are tons and tons of information, and you'll see pros about it and you'll see cons about it. In all the resources you pick, but it's important to kind of get educated on what it is and what the potential ramifications are to you as a consumer. So There's a lot of information out there, and it's going to be more and more and more as this thing expands.
Roland, 100% going to put in the program notes. Roland said, Google it. Like 100%. That's what it's going to be, which is funny. That's what my husband says all the time. If I ask him a question about, like, how do you mow your front yard, or how do you turn on the lawnmower? He'll be like, Google it. So anyway, psyched about that. Well, thank you to the two of you. I know, it was lovely meeting you when we recorded our gene therapy segment a couple of weeks ago, and how lovely to have you back so soon. And now that I know that you're a resource, you'll never get rid of me. Wah, wah.
We're here for it.
You're going to have to come talk about this stuff. I really appreciate the work that you do with our treatment centers and for our patients. I mean, it's sometimes hidden work. Not sometimes. I feel like a lot of stuff that the Alliance does is very hidden from patients in particular. So it's really lovely to bring that to the light and to let them know that you guys are on this and a part of the awareness and education moving forward. So thank you.
Happy to be here. Thanks, Amy.
Thank you.